Hi, I'm Sarah Hornbuckle, an RN student at Fort Hays State University in the class Nursing 450, and I'd like to talk to you about educational glycemic management for the surgical patient and medical staff, understanding the necessity to monitoring blood sugars in 2018 Change Project. Here are some key recommendations. Through careful planning and understanding specific needs of all surgical patients is required at all stages of their pathway from general practitioner referrals to the postoperative discharge. And this will show how we are testing for blood sugars, what we are using, and then the goal of trying to fix the missing puzzle piece in our glycemic management program. So the objectives are implementing and developing the Change Project. A quick pre-test to go over kind of some of the topics that we are needing to address to make a change project and what we are looking at. The change theory, the various factors influencing the preoperative phases, the absence of a standardized protocol causes, and everyone must be aware, and why there is a need for a protocol. Then we go into the patient's pathway with the protocol in place, and we also look at what glycemic management protocols provides, how to monitor patients, how to control blood sugars, and then that quick post-test to discover the outcomes, and then we introduce the preoperative glycemic management. And I want to thank you all for listening. Here we go. By implementing and developing a change project, one can focus on a patient individually. They can have early identification of things that might happen or they might have, such as comorbidities or such as diabetics, and also uncontrolled blood sugars or pre-diabetics. You can have a comprehensive, it can be standardized, and it's a care pathway involvement. It inputs for the team, and it's very good and helps for transition of care. It provides staff with education. Here is the pre-test, and I would like you to notice that we were going to have 5 questions to see what you know about glycemic management, followed by the Change Project. Question 1. Why control blood glucose? Does it improve leukocyte functions, which improves tissue healing, decreases morbidities, mortality, significantly reduces pneumococcal infections? Or does it reduction in acute renal failure through osmotic diuresis, leading to reduced stress on the kidneys? Or does it reduce risk of poor outcomes associated with MI and stroke? Or could it be all the above? Question 2. What is uncontrolled blood sugars called? I'd like you to select all that applies. Is it hyperglycemia, hypoglycemia, having smooth skin, having uncontrolled or unknown diabetes, or having other comorbidities such as ischemic heart disease, heart failure, respiratory disease, or impaired renal function? Which of the following are common barriers for management of hyperglycemia in your practice? Select all that applies. Is it low-level insulin knowledge? Could it be complications of insulin regimens from inpatient specific? Or could it be blood glucose monitoring are readily available? Could it be surgical stress and undiagnosed diabetes? Pick the ones that you know. Okay, question number 4. What is glycemic targets? Recommended by several organizations. And here's the great list of them. And they are looking out for that specific target range. So we have 3 choices here. Pick the greatest one. There's a random and a predominant blood glucose target. Question 5. Hospitals can design a multidisciplinary task force involving the participation of representatives from the pharmacy, anesthesiology, surgery, nursing, critical care, and endocrinology to provide better glycemic control in patients undergoing and recovering from surgery. When should these multidisciplinary checks test and collect a hemoglobin A1C? From the initial visit with the surgeon, J of surgery, 30 minutes after initial incision and hourly until first meal on an elevated fingerstick blood glucose greater than 180 every 4 to 6 hours between meals, or feeling not right? Or could it be all the above? Transitioning for better health through theory, learning, control, and prevention. Change theory from Kurt Lewin. Lewin's change theory contains a change agent that proceeds through the 3 stages to establish the change as a pertinent part of the system. And from our glycemic management program, where guides the progress of the health intervention and influence the concepts that can be rendered into programs, messages, and strategies, which offers the basics for the program evaluation. So we're going to ensure that the employees are ready for the change. We're going to execute the extended change, and we're going to ensure that the change becomes permanent. And that is what our glycemic management protocol is all about. We also are going off the Noel Pinder health promotion model of HPM. The model is designed to support people in making necessary lifestyle changes, as the model is created upon the presumption that people wishes to maximize their health potential and possessing enough self-awareness to grow in their capacity to self-regulate. Pinder 2013. And a health promotion model is particularly useful for uncontrolled blood glucose education because there is no focus on the end of life care, and it is not particularly abstract. It is focusing at the time and present. So, patients with uncontrolled blood glucose sugars preoperatively are more susceptible to complications, infections, increased lengths of stay, and readmissions. My goodness. So here we have the approach to the management of hyperglycemic, from patients to disease with their features underneath. It shows that the more to the left we have more stringent, they got low, and they're pretty much ready to, they're doing very well. Then we got the middle, which is the A1C of 7%. It's a mild area. Then we got the less stringent. That means that you guys are not focusing on your risk and adverse effects and stuff, or the hospital is not. We're needing more support. So this goes through all the different types of how to approach the management of hyperglycemia. Various factors influence preoperative phases. Did you know that nutritional intake, blood glucose lowering medications, activity levels, stress hormones, infection, pain management, and patient psychological state all affect glycemic management? The absence of a standardized protocol causes failure to identify patients, no opportunity for pre-admission planning, lack of institutional guidelines for management, poor knowledge of uncontrolled blood glucose among staff delivering care, complex polypharmacy and insulin prescribing errors, incorrect prescriptions omitted in the error or carefully stopped and never restarted, continued inappropriately, or drug-to-drug interaction. Increased unexpected costs for both the patient and the facilities, ultimately causing harm. Everyone must be aware of the metabolic responses from surgery that it causes and can cause hyperglycemia. Stress hyperglycemia can occur in any patient, since surgery is frequently accompanied by a period of starvation, which induces a catabolic state. Major surgery leads to metabolic stress with an increase in catabolic hormone secretion and leads into an inhibition of anabolic hormones, particularly insulin, which then can lead into a transient hyperglycemia effect. The initial inhibition of insulin secretion is followed by post-operatively by a period of insulin resistance, so that a major surgery results in a state of functional insulin insufficiency, which then can lead and get corrected within 48 hours. But if it does not get corrected in 48 hours, we'll need to aggressively address it for up to 2 weeks. If after 2 weeks it's still ineffective, then 6 weeks will be retested, and if you still have insulin insufficiency, you will be classified as a diabetic. The slides above that we have already researched and learned about all the adverse outcomes, the reasons that hyperglycemic causes, and what stress causes, is the real reason why we need this protocol. It ensures the patients have a realistic outlook, informed, and they grasp treatment options. They ensure the proper medication were took or withheld. They can optimize blood sugar testing from finger sticks on every surgical patient at the initial surgeon visit, the day of, and within 30 minutes from the initial incision, and hourly until patient's first meal, and any signs of uncontrolled blood sugars. They can optimize the target range of blood glucose levels of a pre-meal glucose of less than 140 milligrams per deciliter, and a random blood glucose of less than 180 milligrams per deciliter in a particular, and they can aim for hemoglobin less than 6.7% prior to surgery, treating intraoperatively greater than 140 with a basal bolus infusion to control glycemic management. The new guidelines will cover all stages of patient's pathway from primary care referrals, surgical outpatients, preoperative assessment, hospital admission, surgery, postoperative care, discharge. The process should be seamless with a progressive planning throughout, which is called the team. The underlying principle in glycemic management is the minimizing the planning and the coordination of all aspects of the patient's pathway, ensuring a safe and healthy outcome. Patient's pathway broken down into a primary care referral, going all the way to the discharge follow-up. And here we go. Primary care before referral for elective procedures. This will get to clarify the potential effects, outcomes, risks of having surgery. You're going to confirm that the relevant medical information is communicated fully at the time of the referral. Provides a hemoglobin A1C, blood pressure, weight measurements, medications listed, other screenings as applicable. Safeguards that uncontrolled blood sugars and comorbidities are optimal managed before the procedure even gets registered. Surgical outpatients, they'll arrange the preoperative assessment. They'll try to get as soon as possible after the decision is taken to proceed with the surgery to allow optimization of care. They will discuss the day of surgery, admission plans, and they will confer proper tests, labs, and screenings are set up or completed. They will consult with every patient about glycemic management. The finger stick blood glucose screening with testing of the elevated if it's greater than 180, the hemoglobin A1C, notifying your anesthesia, and then primary surgeon if they need to notify if the hemoglobin A1C is greater than 6.7. And then it's considered postponing between the patient's the primary surgeon anesthesia if it's non-emergent, it's elective, and their sugars are way below above 200 and their hemoglobin is way above 6.7 to achieve, and they'll postpone the surgery to achieve a glycemic control for the patient through their primary care physician, but also for their future outcomes. Your preoperative assessment is confirming that your glycemic control is optimized prior to surgery. Your finger stick blood glucose is less than 180. Your hemoglobin A1C is less than 6.7%. Your safeguards that your comorbidities are recognized and optimized prior to admission, and you're confirming plans are in place to adjust other treatments during the preoperative admission preoperative period. Your bridging therapy for warfarin, your renal replacement therapies are all in place. Your identified high-risk patients required a critical care management, and your warrant and management plan is in place to prevent preoperative dyslipidemia. Is a broad term that refers to abnormalities in blood sugar stabilities. So hospital admission, you're confirming that an agreed documented patient plan is linked to all involved in the care pathway, include the patient, the relevant specialist, the anesthesiologist, surgeon, endocrinologist, staff in all the relevant clinical areas, minimize the metabolic consequences, starvation, and your surgical stress. You maintain optimal glycemic control throughout the admission, and you prevent hospital-acquired infections, and you prepare for discharge home, all at your hospital admissions. The theater in recovery is the use of appropriate anesthetics are being used by your anesthesiologist. You're with your fluids and your pain relief. Your minimal invasive operative techniques are being done to reduce postoperative pain and gut dysfunction, promoting early return to normal eating, which maintains your blood glucose level between 6 and 10 millimoles per liter where possible. Postoperative care is huge. You have gone through all your different regimens and you've gone through all your different preoperative protections and you've gone through your theater and you've had your surgery and now you're maintaining and you're waking up. So we want to keep those maintained blood glucose levels appropriately. We want to make sure that you're at acceptable ranges in the awake patient, not on a basal bolus insulin drip, and it's between 4 to 12 millimoles per liter. And using a basal bolus insulin drip, you want to make sure you're 6 to 12 millimoles per liter. You want to maintain that fluid and electrolyte balance, which the nurse and the medical staff will all do. And if you're going up to transferring upstairs to an inpatient, you're going to maintain that fluid balance also with the transition of care upstairs. We want to optimize your pain control to keep that stress down, and we want to encourage early return to normal eating and drinking. So we might even offer you something to drink before you even go upstairs if you're awake and able to swallow. And we hear gut sounds. We're going to avoid isogenic injuries, so we're going to try to mess things up with drugs, diabetes management, infections, and pressure damage, all in conglomerate to maintain the blood glucose levels appropriately. Discharge planning is essential to be built into the preoperative assessment process. You ensure early discharge as soon as you start the process of wanting to have surgery. You identify factors that are likely to delay discharge, and you ensure any necessary arrangements are in place. So you ensure that plans are in place for safe management of uncontrolled blood sugars post-discharge if that is occurring, and that we really didn't want to, but sometimes that occurs. And we want a follow-up appointment, and we want blood glucose checked even during your recovery at home or at another facility. So here we go, the glycemic management outline. So we just came from the patient's pathway, and it follows the same thing. We got the preoperative office visits, and that's going to check that A1C prior. And then if the A1C has situations, they're going to be dealt with on the left or the right. If everything is good, we're going to proceed on the night before surgery. And we're going to have you do a regimen. And then the morning of surgery, we're going to have a finger stick blood sugar. And if it's out of range, we will follow the situations on the left and the right. If it is in with range, if it's good, we're going to proceed on with your surgery. And that is kind of how the outline goes. So here is the post-test. Are you ready? Here's just a few extra questions. Hyperglycemia is, what are some symptoms of hyperglycemia? Hyperglycemia is sometimes caused by illness, injury, stress, or infection. What happens if hyperglycemia is left untreated? Select all that apply. Hyperglycemia is usually treated with, and then let's see what the answers are. There they are. Look at that. So everybody get the answers right? Next question. So we got question 1, and it's going to answer it really quickly because these are the ones that we did before. Question 2 is also, we'll select all that apply before. I don't know if it's going to answer them as quickly as I'd like. And then, which of the following are common barriers for management of hyperglycemia? And here's the answers. And then the question 4, the prenatal blood glucose target range. Yep, there's A. And then hospitals can design multidisciplinary team forces involving the participation of outcomes. Finale, we are to the end almost. By having a glycemic management, the implementation of a WHO surgical safety checklist is in check. The initiation of the top 10 prevention guidelines for SSIs are being used. Training is established for blood glucose measurements, and controlled blood glucose is being monitored and found and discovered. The continuity pathway is formed with the various medical personnel in different departments. The establishment of standard guidelines enhances timeframes for monitoring, checking blood glucose, and treatment plans, and the trust is formed in the patients through the safety measures throughout their pathway. And here are all my references. Hopefully they will be helpful if you need to use them. And the sad truth is prediabetes is 86 million people. More than 1 out of 3 adults have prediabetes. And the reason why it was very prevalent that in our surgery department is the number 9 out of 10 do not know they have prediabetes. And blood sugars have caused severe problems in the outcomes for surgical patients. And that is why glycemic management is really needed. And there you go. Preoperative glycemic management for diabetics and non-diabetics. Comprehensive care pathway to reduce surgical site infections, length of stay, and readmissions from uncontrolled blood sugars. I want to thank everyone for coming today for this educational, and thank you for listening.